All right, good afternoon, everyone, and thank you for joining us today. It is my pleasure to welcome you today to the Hemophilia Eras Tour, a blank space for emerging therapies. Before we begin, I want to share a few reminders. To participate in audience response questions, use your mobile device camera to scan the QR code on the polling slide. Click on the link that pops up and the poll will open through an app called Slido. You will also see a tab for Q&A in Slido. Please hold your questions until the end of the session. You may use the aisle microphones or the Slido app. We will take microphone questions first. Make sure to write down the unique CE code at the end of the session in order to submit for CE credit in HOPA Learn. See the conference program book for full instructions on how to claim credits in HOPA Learn. And finally, for the sessions you missed, don't worry. You will be able to access them later on-demand in HOPA Learn. The full conference on-demand bundle is included with your registration and will automatically appear in your HOPA Learn account when it is released in May. It is my pleasure to introduce today's speaker, Dr. Maddie Oakes. Dr. Oakes is a clinical pharmacy specialist in inpatient hematology at Michigan Medicine. I will now hand it over to you.
Thanks, Michelle. Welcome to the Hemophilia Eras Tour. While no Ticketmaster Great War for entrance, this room is giving NFL stadium vibes. No conflicts to disclose. And here are a list of abbreviations I'll be referencing today. So throughout the presentation, we'll start by reviewing the previous eras of hemophilia treatment to ultimately understand the optimal place in therapy for novel agents, applying both data and patient-specific characteristics. So hemophilia A and B are X-linked inherited bleeding disorders, resulting in a deficiency of factor VIII and IX, respectively. Classification of hemophilia severity based on factor concentrations, with less than 1% indicating severe disease, 1 to 5% moderate, and 5 to less than 40% mild, are based on a paper describing the relationship between bleeding and factor activity levels, published in 1958 and still used today. However, factor concentrations alone don't account for heterogeneity, with some patients with moderate hemophilia having a more severe bleeding phenotype. One of the most serious complications of treatment for hemophilia A and B with factor VIII and IX concentrates is the development of inhibitory antibodies, occurring in about 30% of patients with hemophilia A, 5% of patients with hemophilia B, making treatment with replacement therapy ineffective and requiring the use of bypassing agents, which are suboptimal for prophylaxis given their short half-life. So since that study was published in 1958, treatment options in hemophilia have changed drastically, from the historical FFP and cryo to the more recent plasma-derived and then recombinant factor VIII and IX products, which have drastically changed hemophilia treatment, allowing for prophylaxis. And the importance of prophylaxis was demonstrated by the Joint Outcome Study in 2007. Which, as compared to episodic or on-demand therapy, found that prophylaxis decreased joint damage to 7% compared to 45% with on-demand therapy. And it decreased the frequency of joint and other hemorrhages, as demonstrated by the blue bars, compared to episodic therapy in the yellow and the gray. Subsequently, the SPINART trial demonstrated the importance of starting prophylaxis early to prevent arthropathy, as prophylaxis started late, defined as after joint bleeding onset, while it improved function, quality of life, activity, and pain, did not improve joint structure on MRI. Because of this, guidelines recommend prophylaxis with all patients with a severe bleeding phenotype, and that is irrespective of lab-based severity. So what factor thresholds should we be targeting with prophylaxis? As shown on the right, data analyzed based on baseline factor levels found that patients with factor levels less than 1% are at the highest risk of annualized joint bleeding. Historically, the goal with traditional factor prophylaxis was to keep levels above 1%, converting patients from severe into the moderate range. However, we know that factor levels of 1 to 3% don't completely prevent all bleeding, resulting in gradual progression of joint disease. This historical target was really based on feasibility, as the treatment burden was significant just to keep factor levels above 1% with standard half-life prophylaxis. So with the cloning of the genes for factor VIII and IX and subsequent development of recombinant factor VIII and IX products, hemophilia treatment was then pretty stagnant for the next about 20 years until 2017 with a new era of non-factor therapies, and then an explosion of new drug approvals in the last 3 years, including the long-awaited gene therapy, of which one agent has since been discontinued. And this explosion of new approvals is so rapid, since the deadline for these slides, fitusiran was FDA approved just 2 weeks ago. So that brings us to our first era today. We will speak now about extended half-life factor VIII and IX products, which have been around for about 10 years. There are a number of different bioengineering strategies used to prolong the half-life of recombinant factor VIII and IX, including fusion to the Fc domain of IgG1 or albumin, as well as factor conjugation with polyethylene glycol. While these bioengineering strategies significantly prolong the half-life of factor IX 3 to 5-fold, decreasing frequency of administration of prophylaxis from twice weekly to every 7 to 14 days, as you can see, half-life prolongation for factor VIII was much less impressive, only 1.5-fold, decreasing frequency of administration of prophylaxis from 3 times weekly to twice weekly. Now, the half-life of factor VIII is roughly 8 to 12 hours. So with standard half-life prophylaxis, that requires administration roughly every other day, and it results in these peaks and troughs, whereas you can see in orange, patients may fall below a critical level and are at risk for breakthrough bleeding. There's kind of 2 approaches with extended half-life factor VIII prophylaxis. One would be to administer it at a reduced frequency, for example, once weekly, with the benefit of reducing treatment burden at the expense of patients still spending some amount of time below a critical level. Alternatively, extended half-life factor VIII can be administered at a similar frequency to standard half-life factor VIII with the goal of targeting higher trough levels and improving joint protection. So current World Federation of Hemophilia guidelines recommend targeting trough factor levels of at least 3 to 5%, which really wasn't possible prior to the era of extended half-life products. With the 2 approaches we just described, this allows us to individualize prophylaxis for patients. So for patients who only perform mild physical activity, they can probably get away. They're getting sufficient protection with lower trough levels, and we can reduce their treatment burden. In contrast, for patients who perform more intense physical activity or high-risk work-related activities, targeting a higher trough level is likely needed. So as we shift our mindset from what was previously feasible to what is now optimal, considerations for the ideal prophylactic regimen include one in which all patients are eligible, one that improves quality of life and adherence, targeting 0 bleeds and no joint damage. While extended half-life products are available for both patients with hemophilia A and B, patients with high titer inhibitors remain ineligible. Again, while factor IX extended half-life can be administered just once every 7 to 14 days, factor VIII still requires frequent administration, and both still require IV administration. With extended half-life products, we're still getting some peaks and troughs where patients spend some amount of time below a critical level, and therefore still at risk for breakthrough bleeding, and joint damage isn't 0. So that brings us to our first ARS question. Which of the following is a limitation of both standard and extended half-life factor VIII replacement? Is it A, IV administration more than once per week? B, patients with high titer inhibitors are ineligible? C, lack of steady state hemostasis? Or D, all of the above? And fingers crossed, polling results show up on the next slide. There we go. All of the above, correct. So clear opportunities for improvement for our patients. So the treatment paradigm didn't really shift too much with extended half-life products, especially factor VIII. As we remember all too well, half-life prolongation with extended half-life factor VIII was very modest in comparison to factor IX. Why is this? Well, the half-life of factor VIII is limited by the ceiling effect imposed on factor VIII by its affinity to von Willebrand factor, or VWF. So at steady state, majority of factor VIII circulates bound to VWF. Typically, this is a good thing, as VWF protects factor VIII from early degradation. As you can see, the half-life of free factor VIII is only about 2 hours compared to 12 hours when bound to VWF. However, all factor VIII bound to VWF is subject to clearance via VWF binding to its clearance receptors. Therefore, decoupling of factor VIII from endogenous VWF is needed to increase the half-life of factor VIII beyond this VWF-imposed ceiling. So efanesoctocog alpha, or EFA, is this ultra-long-acting factor VIII, FDA approved in 2023, with essentially 3 components to prolong its half-life. So it's got recombinant factor VIII fused to the FC domain of IgG1, enabling recycling through the neonatal FC receptor pathway, so similar to a lot of our other extended half-life factor VIII products. It also has 2 X10 polypeptides, which shield it from proteolytic degradation, decreasing clearance, very similar to pegylation. And then its novel component. So it covalently linked factor VIII to the D'/D3 domain of VWF. This is the factor VIII binding domain of VWF. In doing so, it's preventing endogenous VWF from binding factor VIII, decoupling it from VWF-mediated clearance. So factor VIII and endogenous VWF are never, ever getting back together, like ever. In addition, since it still has the D'/D3 domain of VWF covalently linked, it provides partial protection from degradation normally provided with endogenous VWF. And a fixed sequence pharmacokinetic study demonstrates that, again, extended half-life factor VIII only mildly prolonged half-life from 11 to 15 hours, compared to 43 hours with EFA, with levels near normal, above 40% for up to 4 days, and about 10% on day 7. I think this represents another shift from what was previously feasible to what is now optimal. While I said WFH guidelines recommend targeting a trough of at least 3 to 5%, these were last updated in 2020 prior to the FDA approval of EFA. We've clearly demonstrated that higher levels are needed to completely prevent all bleeding. What's unclear is how high of a level do we need to target. A Dutch-based study found an additional 18% reduction in joint bleeding for every 1% increase in factor VIII activity levels in patients with mild and moderate hemophilia A. And they estimated no joint bleeding if we could keep factor levels above 15%. In contrast, a US-based study estimated that no, 15% is unlikely to completely prevent all joint bleeding. So again, with once-weekly administration of EFA, we can maintain levels near normal for more than half the week, which can potentially give patients freedom from thinking about timing of a factor administration around their activities, and maybe even perhaps the consideration for more intense physical activity like contact sports, which at least as of the 2020 guidelines were not recommended unless 1, patients were on optimal prophylaxis, and 2, well-educated against the potential risks. So EFA received FDA approval based on the phase 3 Extend-1 trial, which included previously treated patients, defined as at least 150 exposure days, age at least 12 years, and severe hemophilia A. After a 12-month observation pre-study, patients who were previously receiving prophylaxis were treated on arm A with efanesoctocog alpha 50 units per kilo once weekly prophylaxis, and patients previously receiving just on-demand treatment received on-demand EFA in arm B for 26 weeks, followed by prophylaxis for 26 weeks. Our primary endpoint was mean annualized bleeding rate in group A. This is a common endpoint we see in hemophilia trials. They use a negative binomial modeled approach to account for 1, varying levels of follow-up among patients, and 2, the randomness with which bleeds occur. And with EFA prophylaxis, we saw a median annualized bleeding rate of 0, a mean ABR of 0.71. 65% of patients had 0 bleeding episodes, with majority of patients, or 93%, having between 0 and 2 bleeding episodes. Compared to pre-study prophylaxis, EFA reduced mean ABR from 2.96 to 0.69. But what is that pre-study prophylaxis? Great question. Inclusion allowed any marketed factor VIII product, so extended or standard half-life, or emicizumab, as we'll talk about next, for at least 6 of the last 12 months. However, they excluded all patients who received emicizumab within 20 weeks of screening, so I'm going to assume that that pre-study prophylaxis likely does not reflect emicizumab. We also have data for EFA in the pediatric population with Extend Kids, which included patients aged less than 12, again, previously treated patients and severe hemophilia. They received the same dosing as adults, but the primary endpoint was occurrence of inhibitor development, and no patients developed factor VIII inhibitors. We know that the highest risk of inhibitor development is within the first 20 exposures, the remainder within the first 75 exposures. It's unclear to me why a primary endpoint of inhibitor development was chosen when you are automatically including patients who are at a minimal to almost zero risk of developing inhibitors in the first place. And EFA has a slightly shorter half-life in the pediatric population, closer to 38 hours, especially in those less than 6. Otherwise, results look very similar to what we saw in adults, median ABR of 0, 64% of patients with 0 bleed aids. And so in summary, EFA, with a longer half-life, allows once-weekly administration of prophylaxis and the ability to target higher trough levels. So up to this point, all available hemophilia therapies worked by replacing the missing factor. While yes, half-life prolongation has offered significant improvements, remaining unmet needs include a prophylactic option for patients with inhibitors, as bypassing agents are limited by their short half-life, a non-IV route of administration, and the achievement of steady-state hemostasis to avoid these peaks and troughs that we see with factor therapy, where patients are, again, thinking of timing factor administration around activities. Enter our non-factor therapies, the first of which we'll discuss are our factor mimetics. So bispecific antibodies are not unique to malignant hematology. Rather, emicizumab is a bispecific antibody that binds to and bridges activated factor IX and factor X. So it works as a factor VIII mimetic to activate factor X. It has no sequence homology to factor VIII, so it's not affected by, nor does it induce factor VIII inhibitors. So in addition to being the first prophylactic option for patients with hemophilia A with inhibitors, it's also our first subcutaneous prophylactic option in patients with hemophilia A. Unlike factors, which are limited by their peaks and troughs, emicizumab has a prolonged half-life, about 28 days, allowing for administration every 1 to 4 weeks and achieving steady-state hemostasis. After 4 weekly loading doses, maintenance dosing once weekly or every 2 weeks results in similar plasma concentrations of about 50 mics per mil, a little lower at 40 mics per mil in patients receiving maintenance every 4 weeks. Now, emicizumab demonstrates a clear effectiveness plateau. So the ternary complex of activated factor IX, emicizumab, and factor X follow a bell-shaped curve. We're at too high of concentration of emicizumab. Instead of that ternary complex, you're getting more formation of binary complexes. So just emicizumab and activated factor IX, or emicizumab and factor X. Now, this idea of a ceiling effect is not unique to emicizumab, but rather seen with all non-factor therapies, where up to a certain point, further increases in the dose don't offer any additional hemostatic protection. This is relevant because, spoiler alert, in the absence of head-to-head comparative data, I think there still is a significant role for factor products, predominantly in patients who have higher physical activity levels, where we want to target higher factor levels. In addition, all of the non-factor therapies don't completely normalize hemostasis, which means that bypassing agents or factor products are still needed for breakthrough bleeding and perioperatively. So efficacy of emicizumab was demonstrated in the VIII trials, with 55 to 77% of patients having 0 treated bleeds, and that was irrespective of age, inhibitor status, or dosing regimen. Unfortunately, none of these trials randomized patients to prophylaxis with factor VIII or bypassing agent versus emicizumab. Rather, some of these trials included just a small subset of patients from a non-interventional study who received pre-study prophylaxis and then were treated with on-trial emicizumab. As you can see in VIII I and III, a higher percentage of patients who received emicizumab had 0 treated bleeding events. In HAVEN 1, this isn't surprising. We know bypassing agents are limited by their suboptimal half-life. And in the HAVEN 3 Group D, majority of patients, 85%, just received standard half-life factor VIII. So we don't have any data comparing emicizumab to EFA. I also want to point out HAVEN 6, which was the first phase 3 trial conducted specifically in patients with mild or moderate hemophilia A. If you recall, emicizumab achieves hemostasis roughly equivalent to a factor VIII level of 10 to 20%. So I think this begs the question, should patients with mild hemophilia and factor levels within that range be eligible for prophylaxis? And finally, the long-term results of HAVEN 7 will be really interesting because they included patients less than or equal to 12 months. So these are minimally treated or untreated patients, and therefore, with delayed factor VIII exposure, you're probably delaying the onset of inhibitor development, or at least the time when inhibitors develop. And with emicizumab, we saw mean ABRs less than 1 within 6 months and approaching 0, and that was sustained over very long periods of time. I will point out in HAVEN 4, we did see slightly higher mean ABRs, but that was attributed to a single outlier with one patient having 18 bleeds. So what about safety? Well, as a factor VIII mimetic, unlike your natural factor VIII cofactor, emicizumab doesn't have a natural mechanism like proteolysis or dissociation to limit its activity. This, in addition to its prolonged half-life, mean patients are at risk for thrombosis. Risk mitigation was needed as a result of the HAVEN 1 trial, which found events of thrombotic microangiopathy in 3 patients and thrombosis in 2 patients. Notably all with concurrent activated prothrombin complex concentrate, or APCC, at doses of at least 100 units per kilo per day for more than 24 hours. Now, emicizumab and APCC are synergistic on thrombin generation. APCC contains factors 2, activated factor 7, factor 9, factor 10, and just trace amounts of activated factor 9 and activated factor 10. So it essentially contains the substrates for emicizumab. As a result, our subsequent HAVEN trials were amended to recommend preferential use of recombinant activated factor 7 for breakthrough bleeding, and if you had to use APCC, limiting initial doses to 50 units per kilo. What about thrombotic risk with concurrent factor VIII? We had no reports of thrombotic events in the HAVEN trials with factor VIII, although treatment events were typically short, less than 24 hours, and low doses, less than 50 units per kilo per day. Activated factor VIII has a higher affinity for activated factor 9 and factor 10 than emicizumab, so it will outcompete emicizumab for binding to its substrates, resulting in a non-additive coagulation potential. However, theoretically, if you're giving 2 agents that independently have a thrombotic risk, I think at least theoretically one exists. And we have seen some events of thrombosis with concurrent factor VIII based on the EudraVigilance database. The HAVEN trials provide this really helpful guidance to treat breakthrough bleeding with the lowest factor VIII dose required to maintain hemostasis. In addition to reports of thrombosis in TMA, anti-drug antibodies are also rarely associated with emicizumab, even more rarely result in a decline in pharmacokinetics, with only 1 patient discontinuing emicizumab due to loss of efficacy. So to summarize, emicizumab offers our first subcutaneous prophylactic option in patients with Hem A, and really our first prophylactic option in patients with Hem A with inhibitors. It is able to achieve steady-state hemostasis and requires administration just once every 4 weeks. However, it is limited by the need for risk mitigation due to thrombotic complications, predominantly with concurrent APCC. And again, it doesn't normalize hemostasis, so patients still require factor or bypassing agents for breakthrough bleeding or perioperatively. Takes us to our next ARS question. So prior to the FDA approval of rebalancing agents, which patient population had the most unmet need for improved prophylactic options? Is it A, Hem A with or without inhibitors, B, Hem A with inhibitors, C, Hem B with or without inhibitors, or D, Hem B with inhibitors? And I think you can make the argument for patients with Hem B with inhibitors alone or with or without inhibitors, as emicizumab, our only sub-Q option at this point, is not an option for patients with Hem B. So at this point, no sub-Q prophylactic option and no great option in patients with Hem B with inhibitors. So up to this point, we have replacement therapy, which replaces the missing factor 8 or 9. We have substitution therapy, which substitutes for the missing factor 8. And more recently, we have rebalancing agents, which target our natural anticoagulant pathways. So in hemophilia A and B, our procoagulants, either factor 8 or 9, are absent. However, our natural anticoagulants are still there in full activity, which shifts the balance towards a bleeding phenotype. Up to this point, to normalize hemostasis, we focused on increasing procoagulants, either administering factor 8 or 9, bypassing agents, or a factor 8 mimetic. Instead of increasing the procoagulants, what if we knocked down or decreased the function of anticoagulants to normalize hemostasis? This has the potential benefit of all patients with hemophilia A, B, with or without inhibitors being eligible, but as you can guess, not without risks, as almost all of these agents require risk mitigation due to reported thrombotic complications. The first rebalancing agent we'll discuss today targets tissue factor pathway inhibitor, or TFPI. Very briefly, TFPI inactivates activated factor 10 and the tissue factor activated factor 7 complex to downregulate thrombin generation. So marstacimab and concizumab are monoclonal antibodies, which inhibit TFPI to improve thrombin generation. And marstacimab received FDA approval just in October with the conveniently named BASIS trial, based on the BASIS trial, which is currently only available in abstract form. They included male patients aged 12 to 75 with Hem A or B with or without inhibitors. However, we only have prelim data available for the non-inhibitor cohort, and FDA approval is currently only in patients without inhibitors. Notably, patients at high risk of thrombosis were excluded, so a history of venous or arterial thrombosis, ischemic disease, coronary artery disease. After a 6-month period where patients were observed on their prior routine prophylaxis or on-demand treatment, all patients received marstacimab prophylaxis. Unlike the other agents we've discussed today, which are all weight-based dosing, marstacimab dosing is flat, 300 milligrams subcutaneously once, followed by 150 milligrams once weekly. Majority of included patients had Hem A, about 79%, majority receiving routine prophylaxis, about 71%. And again, just prelim data, but it shows us that compared to on-demand treatment, marstacimab reduced mean ABR from 38 to 3.2, and in patients on prior routine prophylaxis, marstacimab reduced mean ABR from 7.9 to 5.1, and that was further reduced to 2.3 with long-term follow-up. To date, we've seen no systemic thromboembolic events, although 20% of patients have had anti-drug antibodies, all of which were low titer and all but one resolved by the end of the study period. Subsequently, concizumab was FDA approved in December in patients with hemophilia A or B with inhibitors as a result of the EXPLORER-7 trial. We're expecting an FDA decision in May for patients without inhibitors based on the more recently published EXPLORER-8. Both EXPLORER-7 and EXPLORER-8 included males age at least 12 with hemophilia A or B, again with inhibitors in EXPLORER-7, without inhibitors in EXPLORER-8. And they randomized patients who were previously receiving on-demand treatment to no prophylaxis in group 1, concizumab prophylaxis in group 2, and the remaining patients were non-randomized to concizumab prophylaxis in group 3 if they were transferred from a prior EXPLORER study, and then group 4 was a whole mix of patients, including those previously on bypassing agent or factor prophylaxis. If you remember, we established the role of prophylaxis with the joint outcome study in 2007, and here 15 years later, we're looking at the same thing. So in EXPLORER-7 in patients with inhibitors, concizumab prophylaxis decreased median ABR from 9.8 to 0 and improved the percentage of patients with zero treated bleeds from 11 to 64%. In patients without inhibitors, concizumab improved the median ABR from 19.6 to 2.9 in patients with Hem A and from 14.9 to 1.6 in patients with Hem B, increasing the percentage of patients with zero treated bleeds from 0 to 33% and 8 to 25% in patients with Hem A and Hem B, respectively. Now, on first look cross-trial comparison, concizumab looks less impressive for some reason in patients without inhibitors. It's possible that this might be attributed to a protocol amendment, which I'll come back to. I think the biggest limitation with both of these trials is the use of a non-prophylactic comparator arm. As while patients with hemophilia B with inhibitors don't have a great prophylaxis option at this point, we know emicizumab is standard of care for patients with hemophilia A with or without inhibitors, or factor prophylaxis an option for all patients without inhibitors. So looking further at group 4 from Explorer 8, which was the subgroup of patients who received pre-study prophylaxis with factor and were observed for at least 24 weeks, and then were continued on maintenance concizumab. Across all trials, outcomes are pretty, or all groups, outcomes are pretty comparable. Median ABRs around 2, zero treated bleeds around 40% of patients. However, concizumab did not meet its non-inferiority compared to prior prophylaxis. If you look at the 95% estimated confidence interval for the annualized bleed rate ratio, the upper bound exceeds the non-inferiority margin of 2. This was attributed to 3 patients who had markedly increased annualized bleeding rates. However, they couldn't identify any common risk factors among these 3 patients, and none of them had neutralizing antibodies. Looking at safety, we saw anti-drug antibodies in 26 and 12% of patients in Explorer 7 and 8 respectively. And despite the exclusion of patients with a history or high risk of thrombosis, we still saw thromboembolic events in 3 patients, including 2 arterial and 3 venous events in these 3 patients, resulting in a clinical hold for both Explorer 7 and Explorer 8. Now, despite the exclusion of patients at high risk of thrombosis, all 3 of these patients had additional risk factors for thrombosis and were receiving concurrent hemostatic medications, either with activated recombinant factor 7 or factor 8. Subsequently, risk mitigation for concizumab included revised mild or moderate bleeding breakthrough bleeding guidance with lower doses of factor and bypassing agents, as outlined on this slide, and elective major surgery was no longer allowed. Additionally, concizumab dosing was revised. So initially, concizumab is given subcutaneously once daily. They continued the same loading dose on day 1, 1 mg per kg, with a lower dose from 0.25 to 0.2 mg per kg starting on day 2, which was ultimately adjusted based on concizumab concentrations at week 4. And they no longer allowed the overlapping of a patient's prior prophylaxis for up to 2 weeks after concizumab was initiated. Now, if you remember, I pointed out on the prior slide that it looked like on first glance, and again, cross-trial comparison, that concizumab was less impressive in patients without inhibitors in Explorer 8. I think it's unlikely that concizumab works differently or is less efficacious depending on inhibitor status based on its mechanism. Rather, in Explorer 7, only 5 of 23 patients in group 2 were randomized after that treatment pause, meaning majority of patients got the higher initial dosing regimen. In contrast, for Explorer 8 in group 2, all patients with efficacy analyzed had treatment or randomized after the treatment pause and were treated on the lower revised dosing regimen. So I think it's at least possible that this revised dosing regimen may impact efficacy, although hopefully with increased safety. So in summary, marstacimab and concizumab are options in patients with hemophilia A or B with inhibitors. Of note, as of right now, marstacimab only has approval in patients without inhibitors, and concizumab in patients with inhibitors. Pediatric patients are currently ineligible, but there are trials ongoing. How do we choose between marstacimab and concizumab? Obviously no comparative data and very just prelim results with marstacimab, but given its decreased treatment burden, once weekly versus once daily. And while patients at high risk of thrombosis were excluded from both trials, currently only concizumab has risk mitigation due to thrombotic events, whereas no thromboembolic events were reported with marstacimab. So I'd currently favor probably marstacimab. But overall, where do our anti-TFPI agents fit within our treatment paradigm? I think for patients with hemophilia A, we have no comparative data with emicizumab, but we do have more data with emicizumab, including in pediatric patients. We have more experience with emicizumab, including breakthrough bleeding and perioperatively. We have more flexibility in dosing emicizumab, ranging from once weekly to every 4 weeks. And both emicizumab and anti-TFPIs have a thrombotic risk. So I would favor continuing emicizumab in our patients with Hem A, potentially reserving anti-TFPI for patients with breakthrough bleeding despite maximum dose emicizumab, acknowledging they could still have breakthrough bleeding. And if they didn't have inhibitors and were okay with IV administration, I'd probably favor factor prophylaxis to target higher levels. For patients with Hem B, I think these are a good option for patients with inhibitors or those who prefer a subcutaneous option. And our next type of rebalancing agents target antithrombin. So antithrombin inhibits coagulation by neutralizing thrombin, or activated factor 2, and activated factor 10, and to a lesser extent, some other procoagulants. As you recall, heparin works by binding antithrombin and potentiating its effects 1,000-fold. It has been observed that patients who have antithrombin deficiency and hemophilia have a more mild bleeding phenotype. So fitusiran is a small interfering RNA that after subcutaneous injection, because it's conjugated to N-acetylgalactosamine, gets taken up by the liver, which is where antithrombin is synthesized. It gets incorporated into this inhibitory complex, which essentially stops the ability of messenger RNA to produce protein, and AT production is halted. Fitusiran has a really short half-life in plasma, only about 3 to 5 hours. However, the AT lowering effects last for months after fitusiran is discontinued, and therefore it can be administered subcutaneously every 1 to 2 months. Of our non-factor therapies, technically, fitusiran is our only agent that has a specific reversal agent in the form of recombinant or plasma antithrombin. Your normal antithrombin levels are about 80 to 120%. With fitusiran, we see antithrombin levels decrease quite quickly around day 7, with a maximal effect at day 28, defined as this onset period, whereafter intra-individual variation AT lowering is minimal. And so again, with fitusiran, AT levels decrease quickly, thrombin generation goes up, mirroring this decline. And it's thought that pediatric patients less than 1 year will be ineligible for treatment with fitusiran because antithrombin levels increase with age, not reaching normal adult values until about 6 months. So fitusiran was compared to on-demand factor or bypassing agent in patients age at least 12 without or with inhibitors in the ATLAS-AB or ATLAS-INH studies respectively. Fitusiran was initially dosed at 80 milligrams subcutaneously once monthly, which we'll circle back to again. And I think the biggest limitations here are, again, the comparison to on-demand therapy. I don't believe emicizumab was FDA approved at the time of ATLAS-INH study design, but again, we know that factor prophylaxis is standard of care in patients without inhibitors. We did finally get this data recently with ATLAS-PPX, which compared fitusiran to factor concentrate or bypassing agent prophylaxis, and found that it significantly reduced median ABR from 4.4 to 0, and improved zero-treated bleeds from 17 to 63%. If we break down that factor prophylaxis or bypassing agent prophylaxis group further, you can see the outcomes are being mostly driven by patients who got factor prophylaxis, as that was the majority, and most of those patients received standard half-life prophylaxis. Notable adverse events with fitusiran include LFT elevation in 19 to 41% of patients across trials, and biliary events in 6 to 15%, and of course, you guessed it, thromboembolic events. So after interim phase 2 data was released, fitusiran trials were placed on hold as a result of a fatal event of cerebral venous sinus thrombosis, which was actually initially misdiagnosed as a subarachnoid hemorrhage, and the patient was treated with additional clotting factor. So that hold was in September of 2017. Risk mitigation with fitusiran was implemented, which included, again, a revised breakthrough bleeding guidance with lower doses of factor or bypassing agents for breakthrough bleeding and perioperatively, and a recommendation to avoid concurrent antifibrinolytics. Trials resumed in December 2017, but were again placed on hold in October 2020 due to an additional 4 non-fatal thrombotic events. And as you can see, most of these occurred with antithrombin levels less than 10 or right around 10%. And so again, they implemented risk mitigation for fitusiran, this time with a revised dosing strategy and updated target antithrombin levels. And so instead of that initial 80 milligram once monthly dose, they started it at 50 milligrams every 2 months. And that was either escalated or de-escalated, both in dose and frequency based on antithrombin levels. With that initial 80 milligram once monthly dosing regimen, we saw antithrombin levels of 10 to 20%. Again, with the risk of thrombosis being when patients are near that 10%. So subsequently, our target was updated to 15 to 35%, which achieves peak thrombin generation roughly equivalent to a factor VIII level of 20 to 40%. And so given that most of our prior data is with that 80 milligram once monthly dosing, the question is whether this antithrombin dosing regimen can maintain efficacy of bleed control with an improved safety profile. The time of this slide deadline, we only had data available in abstract form from ASH, but more recently we did get full publication of Atlas OLE, or the open label extension, which included roughly 286 patients who received the antithrombin-based dosing regimen. Looking at comparative efficacy to prior, I think median ABR was roughly 3.7, a little bit higher than the 0 to 2 with other Atlas trials, and roughly 31% of patients had zero treated bleeds, again a little bit lower than the previous Atlas trials, which are closer to 50 to 65%. Furthermore, there were still 4 thromboembolic events, 3 of which were thought to be not related to fitusiran. All 4 events occurred with antithrombin levels greater than 15%. Their events consisted of an embolic stroke, a cerebral infarct, and 2 post-op venous events. In both of the post-op venous events, patients did receive bypassing agent or factor at doses higher than what was recommended in that breakthrough bleeding management guidance. So in summary, fitusiran just received FDA approval on March 28th, about 2 weeks ago, for patients with hemophilia A or B with or without inhibitors. Adults only, with pediatric data ongoing in patients 1 to 12 years old. So without randomized comparative data to extended half-life products or emicizumab or anti-TFPI, what's the potential role of fitusiran? I'm guessing it would probably be used similarly to marstacimab. It does decrease the treatment burden further. Marstacimab is administered once weekly, whereas fitusiran is given every 1 to 2 months. However, again, with only prelim data, we haven't seen thromboembolic events with marstacimab, whereas fitusiran did require risk mitigation for thromboembolic events. That brings us to our next audience response question. Which of the following risk mitigation strategies are used to reduce the risk of thrombosis for concizumab and fitusiran? Is it A, revised breakthrough bleeding guidance, B, revised dosing strategy based on concizumab and AT levels, respectively, C, revised inclusion and exclusion criteria, or D, A and B? Yes, the correct answer here is A and B. They both required revised breakthrough bleeding guidance and revised dosing strategies. That takes us to our last era of the day. With initial gene therapy trials in 1998, gene therapy has been long awaited as the potential elusive cure for hemophilia. But with this big reputation, is it the end game it's been hyped up to be? So instead of repeatedly replacing the missing factor VIII or IX, the idea with gene therapy is for the patient's own liver to take over production of factor VIII or IX with a single infusion. So in contrast to factor IX, which is naturally produced by hepatocytes, factor VIII is primarily synthesized by liver, sinusoidal, endothelial cells. So given that our hemophilia gene therapies target hepatocytes, factor VIII expression is ectopic. Our hemophilia gene therapies all work similarly, where they package the transgene for factor VIII or IX inside a viral vector, which is then injected into the patient. After which it gets delivered to hepatocytes and then internalized via receptor-mediated endocytosis. The capsid releases the transgene, and then is degraded. The transgene gets delivered to the cell nucleus. It undergoes transcription and then translation, and ultimately you get production of a functional clotting factor protein, which is secreted into plasma. One of our hematologists at Michigan, Steve Pipe, uses a really good analogy of a delivery box, whereas your viral vector is your box, your transgene is inside your box. Your box gets delivered to an address, in this case, the liver, and upon delivery, the box empties its contents, and then the box and its components are recycled by the body. So all of the FDA-approved gene therapies for hemophilia utilize an adeno-associated viral vector, an AAV vector. AAVs are replication defective members of the parvovirus family, so they're non-pathogenic in humans. AAVs were chosen in part because they minimally integrate into DNA and don't have a propensity to integrate at high-risk sites. But take a look at the massive doses of gene therapy. For a tranacogene dezaparvovec, 2 × 10 to the 13 genome copies per kilogram. For a 100-kilogram patient, this is 2 orders of magnitude higher than all the cells and bacteria in their body. So AAVs will integrate in 1 in 1,000 hepatocytes, or 100 to 200 million insertions per liver, but it minimally integrates. AAVs were also chosen because they have a particular ability to get taken up by the liver, which is again our target with our hemophilia gene therapies. AAV less so than some other serotypes, but it has the lowest seroprevalence, so patients are less likely to have pre-existing neutralizing antibodies. With our initial gene therapy trials, factor IX expression was only about 5 to 10%, which you could make the argument that's sufficient for prophylaxis, but not for patients to live normal lives. Luckily, they found a naturally occurring hyperactive factor IX in Padua, Italy, in a patient who had a single mutation resulting in factor IX levels 5 to 10 times higher than wild type. So our current FDA-approved hemophilia gene therapies for hemophilia B both incorporate the factor IX Padua variant. And historically, hemophilia A gene therapy was limited because the size of factor VIII is larger than the viral vector they have to package it in. But valoctocogene roxaparvovec contains a B domain deleted factor VIII, as the B domain is not required for hemostatic function. So what patients are eligible for gene therapy? One of the biggest limitations is that pediatric patients are ineligible. And this is because they have a high hepatocyte cellular turnover, and given that the factor VIII and IX expression cassettes are within episomes, they're not replicated during cell division. Additionally, patients with a history of inhibitors are excluded. While our AAVs are non-pathogenic, we are exposed to them, and some patients will have pre-existing neutralizing antibodies excluding them from gene therapy, with the exception of HOPA and a tranacogene dezaparvovec, which included patients irrespective of neutralizing antibody status. And finally, because we're targeting the liver, if patients had significant liver disease, so severe fibrosis, cirrhosis, active Hep B, active Hep C, they were excluded. One of the biggest remaining questions with gene therapy efficacy is durability. It seems with factor IX, at least, expression is stable. So after administration of a tranacogene dezaparvovec, we see at 1 year median factor IX levels of about 40%, which is, again, this is your near normal non-hemophiliac range. And that's maintained at about 36% at year 3, with 94% of patients remaining free from continuous factor IX prophylaxis. However, still relatively short follow-up, and while the means and medians are right near that near normal range, if you look at the range, there are some patients with very low responses, and there's a lack of predictability on which patients are going to respond. I also want to point out here, if you remember, HOPE-B was the only trial that allowed inclusion of patients irrespective of neutralizing antibodies, and they found that up to a titer of 678, there was no correlation between neutralizing antibody status and factor IX response. In the study, there were 2 patients who had factor IX levels less than 5% throughout. One received only a partial dose. The other had an antibody titer above 3,000. So what we currently don't know, as no patients were included with a titer anywhere between 678 and 3,000, is what the upper limit is for that titer that still allows efficacy. Just going to briefly review Bengene 2, as vidanacogene was just discontinued in February. Again, cross-trial comparison, but with less follow-up, only about 2 years. Median factor IX lower, about 23%, and more patients, 13%, resuming their factor IX prophylaxis. While I said an unknown question with our factor IX gene therapy is durability, I think you can probably make the argument that we do know factor VIII gene therapy is not durable. So after administration of valoctocogene roxaparvovec, while at 1 year, factor VIII levels were about 40%, so near normal, non-hemophiliac range. With each year, we saw subsequent loss of factor activity down to 15% at year 5. It looks like this is probably plateauing, but again, relatively short follow-up, and 18% of patients had resumed prophylaxis at 4 years. Now looking at safety, again, given that gene therapies targets the liver, we see liver toxicity in the form of transaminitis, which is often transient, asymptomatic, but it has been associated with loss of transgene expression and subsequent decline in factor levels. As a result, patients are monitored very closely, steroids started early, and occasionally additional immunosuppressants are required. Across our gene therapies, we saw elevated ALT most commonly with our factor VIII gene therapy, valoctocogene, at 86% of patients, with majority of patients, 79%, requiring steroids, and for a pretty prolonged amount of time with a median of 230 days and 29% of patients requiring additional immunosuppressants. The exact mechanism of this isn't fully understood. It's thought to be immune-mediated with CD8 T cells targeting the capsid protein on the surface of transduced hepatocytes. And we do know it seems to be dependent on vector dose, so higher risk with higher vector doses. To prove this loss of transgene expression and decrease in factor VIII and IX levels, with HOPE-B, 2 years after administration of etranacogene, we saw in the full analysis set a mean factor IX activity of 36.7%. However, this fell to 16% in the 9 patients who received steroids for ALT elevation. And as I previously mentioned, we know that the magnitude of response to gene therapy varies widely among patients, both at the low end, but also at the high end, with some patients, not all of these are FDA approved, having supraphysiologic factor levels. And in some cases, that led to thrombosis. And also in some cases, they initiated prophylactic anticoagulation until patients returned to normal levels. And then, as I previously mentioned as well, I said that AAVs minimally integrate. They don't have a propensity to integrate at high-risk sites, but given their massive doses, we do see some integration, and patients are at risk for malignancy. At least to date, with hemophilia A gene therapy, we have not seen any gene therapy attributed to malignancy, although again, relatively short follow-up, so should still be a point of education for potential patients. So in summary, is gene therapy endgame? I would say certainly not for all patients. We know that pediatric patients, patients with inhibitors, patients with significant liver disease, and some patients with pre-existing neutralizing antibodies are ineligible. I'd also make the argument that given the lack of durability, it's probably also not endgame in hemophilia A. I think for patients with hemophilia B, long-term follow-up will tell. While gene therapy is a one-time administration, patients still require close monitoring for transaminitis for early initiation of steroids. And I think further proving the lack of gene therapy being endgame is that fidanacogene was discontinued in February due to lack of demand. So in summary, in the absence of any randomized comparative data, our only comparative data being a small subgroup of patients who got pre-study prophylaxis with a bypassing agent or standard half-life prophylaxis, neither of which are standard of care, how do we choose the optimal agent for our patients? Ultimately, it comes down to patient preferences and patient characteristics, thinking about patient age, inhibitor status, risk of thrombosis, activity levels, and adherence related to both frequency and route of administration. Again, for patient, I think extended half-life factor IX or EFA continue to play a significant role, especially for patients who have higher physical activity levels, so we can target higher levels with just once weekly administration. I think the role of non-factor therapy is in patients with inhibitors or those who prefer a subcutaneous route of administration. Again, in patients with Hem A, I'd prefer emicizumab, given more data for it and more experience with its use. And then the conversation between marstacimab based in fitusiran based on a risk-benefit of reducing the treatment burden and a potentially higher risk of thromboembolism with fitusiran. And where does gene therapy fit in? I don't know if hemophilia A gene therapy has a role, especially with the expanding treatment armamentarium. And I think we'll see the role of Hem B gene therapy with more longer-term follow-up. So that brings us to our final audience response question. TL is a 17-year-old male with severe hemophilia A without inhibitors who plays high school varsity basketball. He's currently on standard half-life prophylaxis 3 times weekly, but is having occasional bleeding, especially given his increased number of practices and games during the season. Which of the following is the best option for prophylaxis? A, continue standard half-life prophy. B, switch to extended half-life prophy. C, switch to EFA prophy. Or D, switch to emicizumab prophy. The best choice here, I would say, is switching to EFA because you want to target a higher activity level or a higher factor level in patients who are performing more intense physical activities. I don't think emicizumab is inherently wrong. However, emicizumab doesn't completely normalize hemostasis. So in summary, while we've seen significant improvements to our replacement therapy with extended half-life factor IX and decoupling factor VIII from VWF with EFA, allowing once-weekly administration, and higher factor levels, allowing some freedom from timing factor around activity levels, they're still limited by patients with inhibitors being ineligible and the peaks and troughs. With non-factor therapies, they're an option in patients with inhibitors. They're administered sub-Q, and they achieve steady-state hemostasis, but are limited because they don't normalize hemostasis, so bypassing agents and factor products are still required for breakthrough bleeding and perioperatively, and almost all of them require risk mitigation for thrombotic complications. While gene therapy is a single infusion event which may liberate patients from prophylaxis, limitations include unknown long-term durability, unknown long-term safety, and limited patient eligibility. Ultimately, prophylaxis should be individualized, considering patient preferences, adherence, activity level, and the one thing I didn't talk about today is cost. Like our Taylor Swift Eras tickets, all of these therapies are quite expensive. Most notably, our gene therapies coming in hot at $2.9 and $3.5 million. And with that, what questions can I answer?
We do have one question actually in the app. All right. Does emicizumab APCC risk dose take into account body weight used for dosing? For instance, ideal body weight, total body weight, and understanding that, would 100 per kilogram of ideal body weight dosing have the risk?
Yeah, to my knowledge, none of the dosing recommendations take weight into account, with most dosing recommendations being on actual body weight. We do have data, mostly with factor VIII, that it doesn't distribute into fat, and so you can dose it probably based on ideal body weight or adjusted body weight. I've admittedly never used APCC in patients on emicizumab, but if I did and I had an obese patient, I would probably dose it dose it based on ideal or adjusted, as I wouldn't anticipate it distributes into adipose tissue. Any in-person questions? Be brave. No takers? I tried.
Thank you.
Thanks.